My name is John D. Kelly IV, and I want to welcome you all to Penn Medicine Valley Forge. I'm new to this office, as you are too, and this is one of the new Penn projects. So we opened the office probably, I'm going to say 6 months ago, and I love it because it's close to my home. I live right down the road, and I hope you all enjoy this evening. We're going to talk about something that's kind of a passionate subject of mine, shoulder arthritis. And I'm an arthroscopist, which means I do a lot of arthroscopy. I pride myself when trying to be as minimally invasive as possible, because many of the problems we see in orthopedics today can be treated with the arthroscope. Now, some problems can't, and some problems do require open surgery. And I stopped doing a lot of open surgery years ago as it became more specialized. We do have two very talented shoulder surgeons on staff, Dr. Glazer, who's here, and Dr. Huffman. So things that are really out of the realm of arthroscopy, I will send to them. But shoulder arthritis is not as common as knee arthritis or hip arthritis. So here's the problem that we see. What do we do with the patient, say someone like Lee Kennedy in the back, who's too young, way too young for a shoulder replacement? What do you do? What do you do when you see someone like this, but you don't want this? Now, this is a great operation, and I've done these. Now, I'm not here to diss replacements. They're a wonderful operation, but there's sometimes other options that we can use in an effort to avoid that. And once you've had an artificial joint, you can't go back. You can't do anything else. Your only other option is another joint. So this is what an artificial shoulder looks like, a great operation, but the patients that have done it will tell me, pain's great, doc, but it doesn't feel like a normal shoulder. So what do you do with the person who's young or young at heart? And that's what we're here to talk about tonight. Someone who doesn't want the final common pathway. Now, this slide has real meaning for me. What this looks at is from the Centers for Disease Control, the life expectancy of someone who's 50, 55, 60. Now, if you're like my friend Lee Kennedy in the back and you're 50, you have about 31 years of life expected. So the moral of the story is the longer you live, the longer you live. If you get to 50, you get about 31 years left. The point is, that's an awful long time to have something like this last. As we say in Italiano, capisci? Capisci. So I'm here to say there are options we can use to avert that. Even if you get to 65, you have about 19 years left of good living. That's a lot for implants to endure. So what do you do with arthritis in the young or the young at heart? There's all kinds of options. And this is what Francesco had, AVN, avascular necrosis, or what's primary OA. That's something that there's no known risk factor. It just happened. And I want those of you in the audience that are sober and alive and well, look at your hands right now. And if you see a lot of spurs on your hands, then you may be at risk for arthritis. There are genetics involved here. My father was a real character. He was a good man. He was Irish in every way. He was a politician, was an AA, will give you the shirt off his back, and would fight anybody, anytime. But he tore his, but he tore his meniscus, his cartilage in his knee in college. And I said to him, Dad, what knee was it? He said, I forget. Now, there's a guy who's genetically privileged against arthritis. I did not get his genes. I got my grandmother's genes, who had hands like this, but she lived to be 98. So, there's always a blessing in life. Some studies say that maybe if you have arthritis, you have maybe higher longevity too. So primary OA is, it just happens, genetics, trauma, but I can look at someone, and sometimes you'll scope someone's knee, you'll see no meniscus tear, they're not really overweight, they've had no trauma, and their joint just wears out. That's primary OA, genetic basis to it. Iatrogenic, what's that mean? Well, sometimes we do things as doctors. I get the Greek word iatros. What's your lineage, ma'am? Are you Greek? Hungarian, okay. Remember Freddie Prinze, the comedian? He was half Hungarian, half Puerto Rican. He called himself a Hungarican. Isn't yo a word mean good in Hungarian? Yo, that's the only word I know. Yo! Yo! It means good. I do stand-up comedy as a hobby. Who was one of the greatest American-Hungarian comedians of all time? Died in a tragic car crash in the 60s. You know this, Pat? Remember him? He gave Hungarians a name in America, Ernie Kovács. Ernie Kovács. Kovacs, but his real name in Hungary was Kovács. Inflammatory arthritis, that's rheumatoid arthritis, Reiter syndrome, psoriatic arthritis. Infection, if you get an infection in a joint, one of the reasons I'm so compulsive in the OR is if you get an infection in a joint, you're done. I mean, it's a tough thing. Your joint's never the same. So someone who's had an infected shoulder, for instance, is at risk for shoulder arthritis. The good news is the only time I see an infected shoulder is someone who's really, really sick. Someone who's had like kidney transplants and like end-stage diabetes. And I can look at this audience, you all are not in that category. Capsular arthropathy, what do you think that one? Anyone take a guess at that? If someone is a young man or woman and their shoulder dislocates and you make them tight, we can make them too tight surgically so they wear their shoulder out in time. That's called capsular arthropathy. And it happens. So this is one of the examples of this person had an operation 20 years ago. We thought we were doing the right thing. It was called a putty plat, and it was a simple operation. All we did was basically take the soft tissues and just, if someone's shoulder would dislocate, just tighten them in the front, and they didn't go out again. But guess what? They had a stiff shoulder, and it was an arthritis machine. We didn't know any better at the time, and that's what we see, loss of joint space. Here's a guy who's a foreman who has just wear and tear just from doing his job every day, lifting heavy objects so that his shoulder becomes a weight-bearing joint. And here's an operation I used to do years ago. You'd actually take a bone block, attach it to the front of the shoulder, and make sure they got more buttressing in the front. And it made the patient stable, but this is what you see. So whenever you hear the word arthritis, as characterized by x-ray, it's just really a loss of joint space. A loss of joint space. So shoulder arthritis in a younger person and young at heart can be really debilitating. The shoulder replacement is the most effective way to take care of your pain, but if you're less than 50 or if you're really active, I would try to discourage it and make it your last option. And sometimes it's the only realistic option. And we have some very talented shoulder surgeons here. Dr. Glazer is a world-known researcher, and Dr. Hoffman is a very, very productive researcher as well. One of the things I love about being at Penn is we're doing all this. I was at Temple for 18 years. One of the reasons I loved coming back was I trained here is the research mindset here. We're doing all this cutting edge stuff. I love being part of, what's the next best thing for the patients, being involved with the cutting edge research we do downtown. All right, how do we prevent arthritis? If you have mild arthritis, how do you stop it from getting worse? I'm 54 years old. I played a lot of sports. I did a lot of heavy lifting. I got a little shoulder issue now. And I have an old friend who was an athletic trainer. And the athletic trainers have really taught us a lot in sports medicine because they're in the field. They're seeing the athletes every day. I go to the office. I go to the OR. I have a dear friend who was an athletic trainer for probably 35 years. And he has an axiom. He says, I've never met anyone who's lifted heavy who didn't make it to their 50s without a shoulder problem. Think about that one. Anyone out there still like to lift heavy? Good news. Well, I see some people in my office, they're in their 50s and they just can't give it up. They like looking good, big, beach muscle, whatever, but they also like the feeling of lifting. And the truth is, the good Lord did not make your shoulder to bear that weight all those years. So I see a lot of guys, and I did a lot of heavy lifting years ago, just wearing out their shoulders with heavy bench pressing. Infection in the shoulder, the same bug that causes acne, P. acnes, can cause shoulder infections. So we're real careful with prepping when we do any kind of shoulder surgery. Post-shoulder repair, we talked about making young people too tight. And iatrogenic, that word again from Greek, iatros, that means harm. We do surgery sometimes on folks, and we don't know any better, but you put an instrument in the shoulder, an arthroscope, you can bang their cartilage. We used to use heat to shrink tissue. We used local anesthetic, and we know now that can actually cause the joint damage. Even some of the irrigant we use with arthroscopy maybe can wash out some of the nutrients in the joint. And if you put a knot or an anchor in the shoulder to fix the soft tissue problem, that anchor can break loose and cause significant wear and tear. So anything can happen. Now, this is an x-ray I want to show you that this well-intentioned doctor tried to fix this person's shoulder. It was dislocating, so he put these anchors in and tried to tack down the capsule, and look at the anchors are loose. Look at that. So it's like having a piece of gravel in a ball bearing. When God made our joints, I'll give you some biomechanics here. The coefficient of friction, we call it. Anyone in the audience engineer? All right, anyone in the audience take high school physics? Okay. The coefficient of friction is a term we use to see how slippery something is. Oh, you have ice. The most slippery thing you can imagine is ice on ice, right? When the Creator made our joints, the knee joint, for instance, the coefficient of friction of the knee joint is 10 times slipperier than ice on ice. That's how slippery our joints are. So you take a loose piece like that and you put it in the joint, and it's experiencing stress it never ever imagined it would see, and it wears out very fast. When we fix shoulders that dislocate, if you have one proud anchor, it can erode the tissue, and this is actually bare bone. So we have to be careful what we do. One of the things that the blessing of my training was I trained here at Penn, and I did a special year at Temple, and I had one of these wonderful mentors for years, a guy named John Lockman, who extremely conservative. He taught me that, you know, most things we see in this business get better on their own. Remember that, most things we see, most things. And we have a lot of ambitious young people out there that want to do the right thing, heal with steel, but sometimes you make people worse with surgery. So I try to live my life that way. Primum non nocere, first do no harm. And we've hurt a lot of folks with some of these ambitious surgeries. 10 years ago, someone had an idea and said, well, if you heat tissue, it shrinks. So all these loose shoulders, we saw swimmers, throwers, we're getting this thing called thermal capsulorrhaphy. The well-intentioned surgeon will put the probe in and heat the tissue and shrink it, only to find that at the time they're shrinking the tissue, they're also nuking the cartilage cells. And you see this poor loss of joint space, this young person, and I've seen these folks in the office, they come drifting in, they're in their 20s, and they have excruciating pain because some well-intentioned doctor tried to shrink their capsule. And this is 12 months after a labral repair and a thermal shrinkage. And this kid is really in a tough situation. Infection can destroy joint. Sometimes we get these low-grade infections like after a surgery. Remember, the people that get spontaneous infections are pretty rip-roaring, pretty bad, and I only see those in really sick people. If I'm at the hospital and someone says, I'd like to see Mr. Smith or Mrs. Smith, we think they have a shoulder infection, they're almost always really sick. You know, on immunosuppressant drugs, kidney transplant, end-stage diabetes. But if you do an operation and if you're not careful to prep the skin, the organisms that live on your skin can invade the joint and have a low-grade infection, low-grade, and the only thing you'll see is pain and slow dissolution of the joint space. So that organism is called Propionibacterium acnes, and it takes several days to culture. Here's something I'm very sensitive to. So if you make someone too tight, say your granddaughter or grandson dislocates your shoulder, they go to a well-intentioned doctor, my shoulder goes out like this, the doctor tightens them up, makes them too tight. What happens when you tighten the joint is we call the joint reactive forces increase. So it's actually increasing the compression of that very, very slippery surface, and the joint can wear out. We see this in someone who had a rotator cuff repair. If the well-intentioned surgeon makes them too tight, sometimes they're so tight they never quite get their motion back, and they end up with an arthritic joint. When Mother Nature made our joints, articular cartilage has no blood supply, has no nerve supply. So anyway, since articular cartilage has no blood supply, it relies on diffusion. That means that the joint fluid carries nutrients to the cells. If you don't have motion in the joint, there's a certain part of the joint that never gets nourished. That's why motion is expression in our rehab. Motion is lotion. Motion. So you show me someone with a stiff joint, either it's a knee joint, hip joint, shoulder joint, they are destined to get arthritis because a certain part of the joint is not getting diffusion of nutrients. So prevention, when we do operations, we have to be careful not to use these thermals or knots, and intra-articular marcaine, lidocaine, or frequent steroids. I get asked all the time, Is the steroid shot bad for my shoulder joint? The answer is yes and no. If your shoulder is really, really inflamed, say you have something called adhesive capsulitis, which happens a lot in women. I see a lot of folks that come into my office with, quote, rotator cuff repairs, women that are middle-aged, but they have a stiff shoulder. Has anyone heard of that diagnosis? Frozen shoulder, we call it. If you're a female and your shoulder hurts and you get it stiff, it's usually not your rotator cuff. I'm sorry, Ben, I'm a moving target for Ben. But women, we think there may be some autoimmune elements. And if you have a history of diabetes or thyroid disease, you're at risk. One of my research interests is diabetes and shoulder stiffness. If you look at every person with a stiff shoulder comes in your office and you test them for a blood glucose level, in one study, 70% of those patients had a sugar issue. And diabetics, everything gets stiff. So if you have a stiff shoulder, it doesn't mean you have arthritis, it means your capsule's getting tight. And some of those patients will respond beautifully to a steroid injection. And I think in that case, the steroid helps them. Steroids long-term do make your cartilage cells lose what we call matrix. So too many steroids are bad, too little may be good in the right indication. How about Novocaine, Marcaine? Anyone ever go to the dentist, get Novocaine shots? All right. There's been some basic research out of Pittsburgh showing that Marcaine and lidocaine, two of the common anesthetics we use, actually are a little toxic to cartilage cells too. So I don't use that. At the end of surgery, I used to always put Marcaine in the joint. Now I just inject the skin because we think that it's we call chondrotoxic, toxic to the cartilage cells. I used to work at Temple, and I still take call here. What other substance we see in penetrating trauma is toxic to chondrocytes? Anyone have an idea? What do we see a lot of violence involving this city? Anybody? There's something called lead arthropathy. If you have a bullet in the joint, it actually is very toxic to the joint cells, to the cartilage cells. We call it lead arthropathy. And it can lead to pretty rapid onset of arthritis in young persons. So we see a gunshot, we see a lot of them, more than I care to mention. We were pretty expedient in getting the bullet out of the joint because long-term it's not a good thing. So how do we treat this young at heart? I don't know if we have a therapist here in the audience tonight. I don't know if we do. Physical therapy is always a good choice. You know, surgery should always be the last option. Last option. I've had numerous orthopedic surgeries myself from my other career. And when you're in that table and they put those lights over you, what's your last thought? Anybody had an operation recently? Your last thought is, well, first mine is, help me God. The second is, do I really need this? So I want my patients, when they're on that table, to think, I've tried everything. Yeah, I really need this. I've tried everything. PT, what is Nutraceuticals? Some patients respond to those, some don't. And I try to find out who the responders are by giving everybody a trial. It gets to be a little expensive, but there's a, I think the NIH did us a disservice. This, what we call GATE study that looked at this, I don't think was the best science ever. And if you look at the results really closely, people with moderate to severe pain did respond to it. So I give my patients glucosamine chondroitin. What are some other nutraceuticals that are out there? I take fish oils that haven't helped my shoulder, but my backstroke's fantastic, Pat. Fish oils are anti-inflammatory, omega-3 fatty acids. So if you have any inflammation in your body, it's a good thing. I'm also going to talk to you about what I call the anti-inflammation diet. Those of you that suffer from hypertension, diabetes, or high cholesterol, you should be on an anti-inflammatory diet, which means what? Sugar is pro-inflammatory. I'm Irish, let's not go there. Alcohol in low doses is actually anti-inflammatory. Those of you in the audience that are over age 50, if you want to lessen your risk of Alzheimer's, diabetes, hypertension, I want you to drink in moderation. I want you to cut out the carbs, have a diet that's rich in omega-3s and low in omega-6s, and I want you to get your exercise. If you do those four things, then your risk of Alzheimer's, any kind of inflammatory associated disease, diabetes, hypertension is lessened significantly. Cortisone, talk about this, hyaluronic acid, debridement. We're going to go through all these options here about minimally invasive. And we also can do cartilage transplant, cadaver replacements. These are a little more invasive. Physical therapy for shoulder arthritis must be done by a skilled therapist. Why is that? Now, a skilled therapist will work with the patient and do very, very gentle stretches, put them on a home program, and work on maybe a couple motions that are useful. Like many of my patients with arthritis will say, if I can only reach in the car, I'd be happy. So you work on that. You can't get it all. And if you really crank and push that patient, you can make them worse. It has to be performed gently, and we also work on posture. You have to find a position that may feel better. Have our patients work on posture. And just a little bit of motion increase may make a big difference to that patient, just a little bit. Posture may help. You have to be really careful when I send someone with arthritis for physiotherapy. The last thing I want them to do is to do strengthening. Because whenever you strengthen a joint, you're also increasing the joint forces across that joint, right? So now I'm going to wear my holistic medicine cap because I have a passion for preventive medicine. Arthritis is really nothing more than oxidation of the joint. Think about it. One of my research interests, again, is diabetes. But diabetes and other inflammatory conditions generate increased free radicals. Those are really, we call reactive oxygen species, which cause tissue damage. So I tell everybody who has a painful affliction, an inflammatory condition, including arthritis, have a diet that's rich in antioxidants, omega-3 fats. Saturated fat and omega-6 fats are pro-inflammatory, and I call it the rainbow diet. If it's colored, it's good. The Mediterranean diet's been extolled recently for its virtues, and one of the things that the Mediterranean diet, where Francesca's from, Italy, Greece, Adriatic Sea, Mediterranean Sea, is omega-3 fatty acids. Olive oil is loaded with antioxidants. Olive oil is loaded with omega-3 fatty acids. Olive oil is full of monosaturated fats, which raise HDL, lower LDL cholesterol, and it's probably one of the best things you can do to your salad. Just sprinkle a little extra olive oil. You may notice your joints feel better because it's anti-inflammatory effects. Lycopene, found in tomatoes, huge anti-inflammatory or antioxidant. Rainbow diet, spinach, it's loaded with something called lutein, which is a powerful antioxidant. So there's actually some basic science research that osteoarthritis is mediated by free radical generation. So if you can flood your body with antioxidants, I think you're lowering your risk of arthritis progression. Anyone hear of the Framingham Heart Study? Anyone in the audience hear about that? The greatest, probably epidemiologic study ever performed. Framingham, Mass, right outside of Boston. They looked at everyone for maybe 40 years, Veronica, was it something like that? They charted their diet, risk factors for heart disease. Well, someone went back and looked at the data and said, well, we know what causes heart disease, saturated fat. Let's look at the arthritis risk factors. And they found that the people in the Framingham Heart Study who took a diet rich in vitamins D and C had less arthritis. Go figure. Vitamin D has become the new wonder drug. It also has significant anti-inflammatory effects. Those of you who suffer from immune-related disorders, God forbid, maybe you had a cancer or you've had a chronic infection, vitamin D will boost your immune system like nothing else I can think of. So make sure you take adequate vitamin D. I take at least 2,000 IUs a day. Probably should take about 1,000, but I took 2,000 because my twin brother, identical twin, he's a good-looking guy, by the way. I didn't get my vitamin D level checked, but his was low. I figured if my twin's low, I'm low. Not good. We should all probably get at some point our 25 hydro. You want to write this down, some of you. 25 hydroxy, 25 OH vitamin D level. That'll give you an idea of the storage potential of your body in vitamin D. And I would bet most women in the audience are woefully low. Most of you. Or as we say in Philadelphia, most of yous are low. I have 2 teenage daughters. I guarantee you their diets are low in vitamin D. Guarantee you. Their idea of a 7-course meal is a hot dog and a 6-pack of soda. So 1,000 a day.
What about
vitamin D of each, vitamin D. So these are the nutraceuticals. I want all of you to look at this. Glucosamine chondroitin, I take it. Omega-3, I take fish oils. SAMe is S-adenosylmethionine, another antioxidant. It's expensive, so I'm not going to recommend it if you don't have the resources, but I think it has a role in arthritis prevention. And a secondary effect of SAMe is what? Anybody know in the audience? What condition does it help? It's good for depression. And those of us of Celtic origin, anybody know what the term Irish melancholia is? Why do you think the Irish drink so much? I think they're prone to depression. So I think SAMe is good. And the other thing is that some of my family practice colleagues recommend fish oils to treat depression. So I start taking 3,000 units of omega-3s. I think my mood's a little better. So antioxidants. There's a product called Labral. Again, I have no financial affiliations. I like this. It's a prescription antioxidant. It's called Labral. I use it sometimes when people can't tolerate Motrin or Aleve or whatever. The herb ginger and turmeric. Anyone in the audience from Indian descent? I think they call it something else in India, but it's a very powerful antioxidant spice, turmeric, you know, curry powder. And ginger. Ginger is also good for what other condition? Anybody know? We do surgery, someone gets nausea. Why do you think mom gave us ginger ale? Actually, there's some studies showing that it does help nausea. Ginger extract, you have to get the extract. So injections, again, the steroids, the Novocaines, they can be toxic. Does anyone know what hyaluronic acid is? Anyone hear of Synvisc? Now, the more advanced your arthritis, the less predictable, but this started in Europe. Maybe 20 years ago, the Europeans said, well, let's look at the joint fluid content of arthritics. And if you analyze the joint fluid, God forbid, say Dottie has knee arthritis, take your sample fluid, look under a microscope, send it to a lab, and it's been shown that hyaluronic acid is a normal component of joint fluid. But in arthritics, it is very low. So the Europeans reasoned, well, what happens if we just throw some hyaluronic acid, which is a naturally occurring substance, into people's knees, see what happens. It was like almost very crude science, and guess what? A good number of people got better. I'm a big believer in positive energy and positive affirmation, and maybe my optimism explains why it helps so much, because I tell patients, I wouldn't be giving this unless I thought it was going to work. So I'm batting about 80, I'm going to guess, 80% response rate, which is pretty good. The numbers we see in the literature about maybe 60% respond, but I think if you exclude the people with bone on bone, I think the hit rate's about 70% or so. So I think it's worth trying. These are cadavers. This is a cadaver shoulder, and I published a paper years back looking at how you can plug up defects in the shoulder arthroscopically. The problem with the cadavers, say when I fill a little pothole in the shoulder, is they may not last forever, and whenever you put a cadaver into somebody's body, you always have a risk of transmitting disease. You know, I only request Irish donors because we know they're sterile because they're soaked in ethanol. Right? Now, I have some colleagues, and they're good guys, but I find a lot of people are very aggressive with this condition. We'll take a young person and they'll put a artificial shoulder joint on the ball and maybe a meniscus, a cartilage, and sew it into the socket. And this has not been shown to last that long. So they're simply ambitious. But here's what I do for the younger person with shoulder arthritis. And this is I call this a 3-decade rosary operation because I pray a lot. And this is a hard operation. But we can take a piece of cadaver skin and put it into the joint and sew it on the socket. And that serves as a spacer. I've done about 8 of these. It's one of the hardest operations we do. And just look how hard this is in your mind's eye. We're going to take this whole patch, put it through a cannula, and anchor it down on the socket. But after, one of the things the nuns taught me was how to, write things down. So if I have an operation that's hard, I go and I write about it. I write it down next time. So if you do it enough, I get a couple of tricks down. The last one I did, I was so happy. I was like, thank you. But you have to, again, pick the right person for this. If they're bone on bone and their humerus is totally flattened, I don't do this. But this is for someone who's got mild to moderate arthritis. And what you basically do, but what we're trying to say, Francesca, is that's that little socket there, and we're actually putting in that patch and we're sewing it down, and the finished product is a patch of tissue that looks like that. There's the ball, there's the socket we got to cover with this cadaver skin, and that serves as a little spacer, and that may work for a few years, but it's hard to do. And again, if you're bone on bone, I don't recommend it. So why do you think people with arthritis have any joint? Why do you think they have pain? Well, since we said that the cartilage has no nerve supply, it can't be the cartilage. What else is in the joint? You have bone and you have soft tissue. Bone is particularly the, we call subchondral bone. The bone that's below the joint has a very rich nerve supply. Anyone in the audience have knee arthritis? I do. You get that pain like, my left hip, I can tell you when it's going to rain. It's like I'm better than, you know, Hurricane Schwartz or whatever that guy's name is. But the bone beneath your joint is very richly innervated. Now, it turns out, just as we have blood pressure, we have bone pressure. So someone at Penn years ago did a nice study and found that if you put someone in a hyperbaric oxygen chamber and lower the barometer, their joint pain got worse. And we think the reason is when the barometer drops, it allows the bone pressure to expand against the walls of the bone. So we think there's we call it osseous hypertension. Maybe I remember from high school science where they put the balloon in the bell jar and the teacher would suck out the air and the balloon would expand. Same thing happens to the blood vessels and the nerves in your bone. When the barometer drops, we think that it allows the intraosseous pressure to expand against the bone walls. That's why it's not so much rain as I think the barometer dropping. So some of my patients will tell me, well, you know what, it's not so much the rain, it's just the change in weather, I think they're right. So bone is very neural. And also some of our folks with arthritis have rotator cuff tears. They have biceps problems. They have arthritis of what we call the AC joint. They get stiff. Their joint gets really stiff. They get a contracture. Then their joints can get incongruent. They sometimes complain of like just catching, locking, ratcheting. And those of you with knee arthritis, sometimes your knee will just catch and give way. So if I have someone who doesn't have severe disease and they failed nutraceuticals and little gentle stretching medications, I will sometimes offer them what I call an arthroscopic debridement. That's a French word for just cleaning, debride. So we just put the scope in and just sort of clean out the rough edges. You flush out all those enzymes. And a lot of our patients have loose bodies. And I'll sometimes just release the capsule, make them looser so they get more motion. And in the right patient, this can be a real godsend. But again, you can't wait till they're so far gone. How about someone with rheumatoid arthritis that has what we call an inflammatory arthritis? We can go in and also remove some soft tissue, clean it out, get rid of some of those enzymes. But we don't know how long it's going to last. And this is a picture of someone with maybe rheumatoid arthritis where it's just diffusely narrow. You don't see spurs. You see kind of a little osteoporosis. That's more an inflammatory arthritis versus osteo, which is more we call proliferative. They get spurs, they get increased bone density. So a scope will help someone who is older but couldn't withstand a big operation. I saw a woman in the office today who was in her 70s, didn't look it, had very significant arthritis, did not want a total shoulder. Said, nope. I said, well, we tried the Synvisc, we tried the therapy, and so I scoped her. And you know, I didn't do a lot. I released a little capsule. I saw her today. She's a happy camper. She is happy. She's still stiff, but she's like, you know what? I can sleep. And I think part of it was just going in there and just sort of washing out the joint and making her just a little. Some of our patients are very stoic, and many of them, we just make them a little better. They're happy, just a little better. When I say a concentric reduced joint, what does that mean to you, Dottie? What do you think that means? If someone has such arthritis that their joint is like, their head is flat and their socket is really eroded, it's like this fellow in the back. He was too late for Synvisc, they're too late for a scope. You know, there's my old teacher, Dr. Lockman, would say, you know, you got to tell the patient, you have to shake hands with the problem. In other words, this is it. I can't promise you the world, and your only option is either live with it or get a new shoulder. Shake hands with it. Younger active patients. I took care of a young kid who had a good surgeon, treated his shoulder, left one anchor proud. He had a dislocating shoulder, unstable shoulder. Just one anchor was left proud and just trashed this kid's joint. So I had to do that skin graft procedure on him. And it was terrible. I put the scope in. I'm like, this kid's a saint. Like 17 years old, just, you know. So, but he was a good candidate for a scope. So if you see this picture, you see how flat this is. See this, Dottie? I look at this x-ray, I say, I can't help you with the scope. You need a new shoulder or you need to live with it. I'll maybe inject that person. And I would lower the bar for the Synvisc in the shoulder. I will do it in bone and bone because, again, we don't put as much demand on our shoulders. So how about this person? Comes in your office, 67, diabetic, CAD means coronary artery disease, hypertension, and they'll tell you, I don't want a new shoulder. What are you going to do? The shots don't work. Can you give me some relief? Well, I think if he has some discernible joint space left and his humeral head is not totally flat, my answer to him will be yes. We can actually take the spur out with the arthroscope. I don't know how much that helps. It may give them a little motion, doesn't help their joint at all. So we can smooth out the rough edges, we can take care of spurs. We use the thermal very carefully. And again, this is better for lower grades arthritis. Now, if you're one of those people with early arthritis, sometimes you put the scope in, you'll see like this little pothole. It turns out, in dogs at least, if you make those edges straighter, the pothole will have less chance of progressing. If you see a pothole in the street, what happens in time? It gets bigger. Well, for some reason, if you bevel the edges with a curette, in the body at least, in an animal study, a dog model, 1987, the pothole got bigger more slowly if you beveled the edges. So sometimes I'll just do that. Now, when we scope a shoulder, don't forget, a lot of these folks with arthritis will also have rotator cuff disease. And how do you tell if someone has a rotator cuff disease? Well, I tell the residents to say, just listen to the patient. If they take their hand, they put it down here, that's almost always a cuff. If they take their hand, they say it hurts on top, that's almost always an AC joint. If they put their hand down here, that's almost always a biceps problem. But if they tell you it's deep here or in the back, it's usually arthritis. So just listen to the patient. They'll tell you where it is. Where it is. This is what you'll see in someone like Francesco, who's a heavy lifter. They may wear out their AC joint. I used to do a lot of heavy bench pressing, and I separated my shoulder in college. So I got an AC joint. If I do some push-ups, it hurts. And sometimes, like I said, I see a lot of saints throughout the week, people that have just lived with really bad problems. And they're just happy to be alive. And if we make those patients a little better, sometimes they're really happy. So we take care of the AC arthritis. Sometimes their biceps gets inflamed. We can treat that. We don't address the shoulder arthritis fully, but you know what? A lot of their pain's better, and they're happy campers. So this is a picture of a scope cleanup. We put the arthroscope in. We can just sort of like do a little bit of what we call buff and shine. This is called a thermal device, and we use this very, very carefully because I mentioned before, if you put it on too long, you actually can hurt the cartilage. But it also is very good at sort of on a lower dosage of smoothing the surfaces out. And some of our patients, if we make their shoulder a little smoother, they'll feel more comfortable. Here's a little video here. Let's see if we can get this to run. Okay, I guess not. Anyway, I had that trouble before, but it works on the flash drive. I think it's the format, Ben, of the video here. But so we don't walk on our arms. It's best if the lesion. So microfracture is a technique where we actually can drill some holes into that little lesion and make fibrocartilage. We do this a lot in the knee. Have you ever heard of microfracture? It's big in athletes now. They come in with a pothole in their knee and just drill some holes in and let blood settle, and bleeding tissue, particularly cells from the bone marrow here, will settle here and become cartilage-like if we treat it gently, because sometimes we call these stem-like cells. If they're in the right environment, they will turn into cartilage-like tissue. That's called microfracture. But I do this if it's focal, if it's surrounded by good tissue. And when we say unipolar, that means if the disease is on one side of the joint. So unipolar means if you have maybe just the ball joint, not the socket. And I do this when I put that patch on too. I'll just get some bleeding surfaces and I put the patch on, and that blood under the patch will turn into cartilage cells in time. So this guy named Millett did a study. He showed that if you microfracture, perforate holes in the joint, create bleeding, he had about 81% success rate, but most patients had other procedures as well. This is called a capsular release. So if someone is really stiff, we just take a little heat knife and just cut the capsule, and give them more motion. Sometimes patients, by virtue of getting more motion, are very, very happy. We don't cure the arthritis. We do release some of the scar, and they're happier. But you need a good therapist post-op, because if you don't get therapy right away, they'll become stiff very, very quickly. So when you release shoulder scar, don't forget that when God made our shoulders, there's a joint and there's something called the subacromial space, the rotator cuff and the area above that. Sometimes folks are stiff in the joint and around the cuff, so you have to release both areas. That's called the subacromial space there. So almost all the stiff shoulders I see usually start out here. They'll have trouble with the arm at the side. And to me, the next thing usually goes is reaching behind like that. If you show me someone with arthritis at their shoulder, one of the things they can't do is, if they're female, undo their bra strap. If they're a guy, have trouble tucking their shirt in. So those two questions are very meaningful. Can you tuck your shirt in? No, I can't get back there. Well, they got a stiffness issue. So this is a little mechanical principle. I want you to put your thinking caps on now. I have a shoulder. I'm moving it. My deltoid's working, okay? Our shoulder joint works as a fulcrum, right? If that shoulder is stiffer, it's going to require more muscle power to move it. That means the fulcrum gets compressed more. What I'm getting at is this. Sometimes if you just loosen the joint gently, you're actually decreasing the forces across the joint. So I'm a big believer in stretching joints that have mild to moderate arthritis. So more muscles required, more force across the joint. And this is the reason why we get arthritis mostly in the back. When you take an x-ray of someone with shoulder arthritis, usually the back of the socket wears out more than the front. And the front of the shoulder joint usually is the one that's stiff. Remember I mentioned before, it stiffens first? If the front of the shoulder stiffens up, it literally pushes the ball back. So we get what we call eccentric wear. You get wear and tear behind first. So when I was doing total shoulders, I would often find that the back of the glenoid, we call it the socket, was worn, the front was actually normal. Now when I scope shoulders, I find that the back is usually worn and the front is usually spared. And I think it's because the reason the front gets stiff, maybe there's more micro trauma, more usage here, maybe those soft tissues get inflamed easier. We live in the front, right? So a capsular release may help reduce the humerus on the glenoid. In other words, if it's sitting back, you release that capsule, it may reduce it. It can help the person with external rotation. And depending on what part of the shoulder is stiff, we can tell where to release it with the arthroscope, because we know from our anatomy that this is the back, this is the front, that's the bottom front, the bottom posterior aspect. We know that releases here, releases here give consequential increases in motion in certain planes. So I can look at someone in the office, and for instance, if they're stiff here, I know I have to release up in here. If they're stiff here, I know I have to release back in here. So the exam is very important to me as to where I target the release. This all makes sense. So I won't bore you with some of these finite details. So when I do the release, I use the thermal device. I'm careful not to injure nerves by hugging, we call the labrum. And we look through the arthroscope wherever we have to. We call contralateral portals, meaning looking from the other side. And we release ligaments. And I do my cases in we call the lateral decubitous position, patient lying on their side. And I use a little traction when the person's asleep to distract their shoulder and give us more working space to use and make the surgery a lot easier. So we release the front, and there's a little thermal device releasing scar. And we actually release it to the point where you actually have almost a Grand Canyon here. And these patients, we do these releases, you examine them pre-op, and you take the scope out, and you put them on the table, and it's like almost immediate release, increase in motion. This is called the posterior capsular release. This is for someone who has difficulty in this motion. That's the posterior inferior capsule. Here is the straight inferior capsule. This is the anterior superior capsule. And this is the anterior inferior capsule. So I can tell from their exam where I need to release. So anyway, if you clean the joint up, you take some of these arthritics that aren't really terrible, if you have a discernible joint space left on X-ray, you can expect, and I tell my patients, pretty good results only average at 3 years, but we'll give you maybe 3 or 4 years of relief if you just do a little bit of soft tissue cleaning. Again, I like to see if the joint is concentric. If it's not, I think of other options. There's a fellow out in Stanford, Dr. Safran, 18 patients with severe arthritis. All he did was scope them, and he found that 78% had good X results at only 2-year follow-up though. It's only 2 years, but still a start. And some of these patients had bone on bone. And you'll look at some of these results of in his study, and these are the 2 to 3 year follow-up, and these are called the UCLA shoulder scales. So the higher is good, lower is bad. So they went from an average of say 14 to 26 or so, and this is at 2 or 3 years, and the relief was sustained. So, you know, I've had a lot of people out there that are happy campers. I had a guy about 3 years ago, tennis player, arthritis, didn't want a new shoulder. I just scoped him, released him, and he's back to playing tennis. I wish I could say every patient does that well. They don't, but some do. So, and look at these satisfaction scales from Dr. Safran's study. Their satisfaction pretty much went down at 6 weeks because they're hurting from the surgery, but by 6 months and 1 year, they're still getting better. And most of them would say they're either between do it again or extremely pleased. I think that's pretty good. And these are kind of the worst comers too. 2 friends of mine, or Dr. McCarty, he said if both sides of the joint were involved, the results were less promising. He didn't do any releases though, at least not in his, he didn't mention that. So there's all kinds of articles I can bore you with showing that if you look at people pre and post-op, their activity scales are better. This is pre, that's post. The light activities, they went from a 3.1 to 6.9. And here's an interesting study, I mean, interesting tidbit. Their rest pain went from 1.9 to 5. So those of you that have difficulty with sleeping, one of the reasons that, one of the criteria I used for someone to get an operation, I say, well, look, we've tried this and this. Are you sleeping at night? If they're not sleeping at night, I say, you know, you better do something because when I don't get my rest, I'm, you know, cranky to my wife. I'm not effective in the office, and you're really not good to anybody. So sleep is so important. And finally, even if you have a rotator cuff tear and arthritis, my friend Dr. Savoy from Louisiana showed that if you fix the cuff and cleaned out their joint, you'd benefit from arthroscopy, even if they had a cuff tear. So a cuff tear doesn't exclude a good result. So this is what I call concentric reduction. So this joint looks like it's sitting back. See that? See how this is sitting back? You see this, folks? I would not want to scope this shoulder. It's just too, we call subluxed. That would not have a predictable outcome. So again, more Latin. What's the truth, I think? Veritas. Counsel patients, and if they're really active, give up benching, heavy lifting, do general stretching. I do believe in hyaluronic acid more so for the shoulder than the knee, believe it or not. I think vitamins are good. We can get them to 50 years old with the scope, and if they're young at heart, they're all active, we can keep them going. It's a tough problem. If we just clean out the joint and release the capsule, take out the spurs, we give many of our patients temporary relief. But don't forget, if the joint is congruent and if the disease is on one side of the joint, you have much better results. And I do a microfracture if the disease is contained. So it doesn't burn any bridges. You do a scope, it doesn't burn a bridge. You can always get a shoulder later. And most of our patients are satisfied if we make them a little better. I had the blessing of working here, involved with some, some very, very smart people who are doing work with growth factors and biologic mediators, gene therapy. The age is upon us. So one of the things I tell my patients is, once you get that new joint, you've burned every bridge. If we can delay this a little longer, the way we're going now with cartilage restoration procedures and with gene therapy and disease modification, it may be worthwhile to try to delay this. So unless there's no discernible joint or profound flattening, I think an arthroscopy is a good operation. Thank you for your time.